For question 16, we examine whether higher protein and fat intake during winter months is linked to national happiness. Winter is defined as December to February across all countries for consistency. The result shows a clear pattern. The US has the highest winter protein and fat intake, 559 and 1328 kilocalories respectively, and also the highest happiness score at 7.12. Brazil follows the same trend, while India shows the lowest intake and the lowest happiness. The correlation analysis confirmed this relationship. Protein intake shows a strong positive correlation with happiness at R equals 0.827, and fat shows an even stronger correlation at R equals 0.904, both statistically significant. This suggests countries with higher winter nutrient intake, especially fat, tend to report higher happiness.
The strong correlations between nutrient intake and happiness do not imply dietary causation. Instead, economic development is the key confounder. Wealthier nations can afford more diverse, nutrient-rich diets and also invest heavily in healthcare, education, and social safety nets, direct contributors to well-being. In contrast, lower-income countries have limited food systems and weaker social infrastructure, leading to both lower nutrient consumption and lower happiness. Cases like Japan and Germany, which have high intake but lower happiness than the US, show that factors such as inequality, work-life balance, and healthcare efficiency also matter. Overall, prosperity, not diet alone, drives the observed correlation.
Now, I'll be talking about, do long-term fat intake trend correlate with happiness? So here are the implementation consideration. We're using the happiness dataset and the daily intake dataset to find the correlation between the happiness level and the fat intake. First, we will have to filter the date from 1961 to 2020, and then we have to find the daily average fat intake for each country. So after using the coding, we can see that there is a strong correlation between the happiness and the average fat intake for each country. A strong correlation of 0.7228 as a matter of fact. That means that the more the citizens and the people intake fat, the more happier they are on average. So is this the only factor we have to consider into happiness? Perhaps there's one more factor that we haven't considered yet with a strong correlation. And that factor is the GDP per capita. As you can see, when we find the correlation between the GDP per capita and the happiness score, there's an even stronger correlation between them. But why is that? Because having a high economic status allows you to access to food with a higher fat content, and at the same time being able to afford more food and lowers the stress on the individuals.
Moving on to question 18, which asks whether countries with lower monthly nutrition variation tend to be happier. The correlation between nutrition's variation and happiness was negative 0.1035, indicating a very weak negative relationship. This suggests that having a more stable nutrition intake does not equate to higher happiness levels. For instance, Algeria and Bhutan both have similar happiness scores of around 5. However, Algeria's nutrition variation of 601 is significantly higher than Bhutan's at 58. This suggests that other social or economic factors play a much larger role in determining happiness than dietary consistency alone.
The idea of happiness remains subjective across countries and individuals. Our dataset doesn't fully capture these nuances. For example, a country with high GDP per capita may have more diverse food options and higher nutrient variation, but this does not necessarily translate to a higher happiness level, because factors like work stress or low life satisfaction can still reduce our overall well-being. The happiness dataset only represents a sample, so it may not accurately reflect the entire population. On top of that, there is a temporal mismatch between the happiness and daily intake datasets. Even though we restricted daily intake to 1961 to 2015, the happiness data reflects only 1 year. This reduces the precision, and ideally, both datasets should align across the same time range for a more accurate comparison. Moving on to question 19, part 1, we consider the Burger King menu dataset. We will only use the burgers and chicken categories, excluding the breakfast menu to avoid skewing the data and causing inaccuracy due to its low nutritional values. We also calculated the average fat content as a percentage of average calories, where 1 gram of fat provides 9 calories and 1 gram of carbohydrates provides 4 calories. Looking at the figure on the left, there is a rising trend of fats and carbohydrates intake over the years. This shows a shift in dietary preferences towards high-calorie and processed foods, which are often associated with increased sugars, fats, and saturated fats. Looking at the picture on the right, the average carbohydrates and fats in the burgers and chicken categories contributed to about 85.3% of the total calories. This high proportion highlights that fast food nutrients replicate that of processed food, showing that both are closely related. Although fast food is not the sole contributor, 11.7% of calories intake comes from fast food, showing the widespread consumption and a strong relationship between processed food intake and fast food menus. Moving on to part 2, fast food is considered to be a subset of processed food due to the shared characteristics of high fats and carbohydrates nutrients, hence using daily intake dataset to represent this group. Additionally, the happiness dataset only has data from the year 2015, thus aligning the daily intake dataset to the same year so as to ensure consistency throughout, giving a more accurate representation. Moving on, the correlation between fats and happiness was found to be 0.7016, while carbohydrates had a weaker correlation at 0.0484. This means that a higher fat intake presents a higher happiness level, suggesting that access to energy-dense food brings happiness. When comparing the top 10 happiest countries and the last 10 happiest countries, the top 10 had a much higher average fat intake. This supports the idea that fast food and processed food consumption influence happiness, not only through nutrition, but also through economic prosperity and food security. Moving on to part 3, the life expectancy dataset only contains data from 2000 to 2015, which we aligned with daily intake to maintain consistency and reduce the deviations. We will also be using the life expectancy variable to compare with the nutrient intake, as life expectancy can represent how long a person lives, which generally relates to a healthier population. As shown in the picture on the left, the average life expectancy increased from about 66 years to 71 years over this period, indicating that the population is generally more healthy due to better access to healthcare and technological advancements. However, the nutrient intake over time also increased, showing a higher intake of processed food diets. Here lies the harsh truth. Life expectancy does not necessarily mean living healthily. People could still suffer from diseases such as cancer or cardiovascular diseases despite living longer. The main lesson is to balance nutrient intake with advancement in medical equipment, ensuring that people not only live longer, but also healthier lives.
Next, does fast food consumption increase health risks and can it be mitigated? First, I looked at which nutrients are most common in fast food meals. Using Burger King's and McDonald's menu datasets, I focused on the overlapping categories such as burgers and chicken, and regular and gourmet respectively. I then calculated the average fat and carbo-calorie content as a percentage of total calories. Results showed that on average, Burger King meals derive 56% of calories from fat, while McDonald's derive 44%. Both far exceed the health guideline of 25 to 30% of total energy from fat. Saturated fat makes up 17 to 18% of calories, which is above the recommended limit of 10%. This means that fat takes up a huge share of total calories, highlighting how energy-dense and fat-heavy fast food meals are. This result aligns with the growing trend of increasing fat calorie intake as countries continue to shift towards fast food-based diets. Next, to identify what indicates health risk, I used the life expectancy dataset and measured body mass index, which is a reliable indicator of weight-related health risk such as heart disease and diabetes. I then examined the relationship between BMI and average daily fat calorie intake across countries. As shown in this scatter plot, there's a moderate positive correlation of 0.5979, suggesting that countries with higher fat calorie intake tend to have higher average BMI. This supports the idea that higher consumption of fatty fast food diets is linked to increased health risks like obesity and heart disease. However, BMI can also be influenced by other factors such as income, age, and lifestyle. To evaluate how income influences this relationship, I split GDP per capita into two categories. For countries with GDP below the average of $12,617, the correlation between fat intake and BMI remained strongly positive at 0.67. But for wealthier countries, it dropped to negative 0.12, showing that higher income can weaken the link between diet and BMI, suggesting that BMI is influenced by other factors other than fat intake. Lastly, to determine whether these health risks can be mitigated, I used a health lifestyle dataset and found that BMI has a slight negative correlation with physical activity of negative 0.607, sleep hours of negative 0.01, and diet score of negative 0.2. Regular exercise helps maintain energy balance and reduce chronic disease risk. Sufficient sleep prevents individuals from making unhealthy food options, while eating healthy and balanced meals such as eating fruits and vegetables and limiting fat intake can lower the risk of heart disease, stroke, and some cancers, hence mitigating health risks arising from fast food consumption.
For question 21, I analysed how the US diet has changed over the past 62 years and what factors explain these shifts. I used two datasets, the daily intake dataset from 1961 to 2022 and the simulated intake dataset from 2015 to 2020, to see both the long-term trend and whether recent eating behaviour follows the same pattern. When we look at the long-term nutrient trends, two patterns stand out clearly. Fat intake has increased sharply, rising by around 55% since 1961, and animal protein intake has also grown steadily. In contrast, carbohydrates remain fairly stable, except for some fluctuations in the 2000s. Together, this trend shows a clear shift away from carb-based diets towards more energy-dense, high-fat, and meat-heavy eating patterns. One way to see this transition more clearly is to look at the fat-to-carbohydrate ratio. It increased from 0.66 in 1961 to 0.88 in 2022, showing that fats are gradually taking up a larger share of the US calorie composition. Next, I examined whether rising fat intake is linked to rising meat consumption. The correlation between fat and animal protein intake is extremely strong, about 0.92. This suggests that as Americans eat more meat and dairy, fat intake increased alongside it. So the growth in animal-based food is a major driver of the overall rise in dietary fat in the US. To make sure these patterns weren't just historical, I compared the long-term supply data with the simulated intake dataset. Even though the simulated data is lower because it measures real consumption rather than national supply, both datasets still shows the same upward pattern from 2015 to 2020. This gives confidence that the long-term changes reflect actual eating behavior. To understand why the US experienced this shift, I look at broader economic patterns. Using GDP per capita from the happiness dataset, there's a strong relationship between national income and both fat and animal protein intake. Richer countries tend to move towards more meat and higher fat foods, and the US fits this pattern clearly. As income rose and industrial agriculture expanded, calorie-dense food became cheaper and much more accessible. Economic factors alone don't explain everything. Social habits also reinforce these trends. Vegetable protein grew only 17% over 6 decades, which is very small compared to fats and animal protein. Convenience culture still dominates. Processed and fast foods are cheap and everywhere. So even though health awareness has increased, real behavior change is slow because of the cost, time, and availability barriers. So in summary, multiple forces like economic, social, and structural work together to push the US towards a long-term, high-fat, meat-heavy diet.
Now, I'll be talking about which month should the government increase public awareness of unhealthy food spikes. So, taking these four datasets into account for this question, we have the three fast food chains and the simulated food intake between 2015 and 2020. This will allow us to find the average calorie intake among all the countries within a single month, and we're able to find it for each month of the year. And as you can see, the highest calorie intake period is from January to May, and the lowest is July to October. But why is that? This is because of the changing of seasons. Because winter and spring has the highest difference of temperature, the change of temperature, our bodies requires more calories because our bodies needs to adapt to the heat, letting the body burn more calories in the meantime. Therefore, we crave to eat more calories to compensate for that loss. So, how can the government push and promote a healthier lifestyle? Here are two methods of advertisement. First is a seasonal themed advertisement where it's based on maybe an ingredient or a celebration. And next one is a health themed advertisement where it blatantly shows you a healthier choice rather than their higher calorific menu items for you to try. So, which menu items should they push as a healthier option? Here are the top 5 lowest calories menu items for each of the 3 fast food chains. So pushing any of these for during the first half of the year will influence their customers to eat any of these rather than the higher calorie options. But if they want to maybe create a new product, a new food menu item, here are some of the ingredients they can use, which are low calorific but also high in other very useful factors. Things like food that are high in carbohydrates but low in calories are pumpkin, watermelon, and popcorn. Food that are high in protein while being low calories are non-fat Greek yogurt, egg whites, and baked skinless chicken breast.
For question 23, I used a mixed quantitative analysis approach with 5 queries. I used the simulated food intake, happiness dataset, and secondary sources like Food 2023 guidelines, OECD 2019 economic analysis, and policy effectiveness studies. To determine the impact of reducing fat or sugar on happiness, I tested for correlation. Fat has a strong positive correlation, which means wealthier countries consume more fat and report higher happiness, but this is not causation. Both variables reflect underlying wealth. Wealthy nations eat more processed foods because they can afford them. They also report higher happiness as income enables healthcare, education, and security. Lower income nations consume more cheap carbs and report lower happiness due to economic stress. This means consuming more fat alone won't improve happiness, and diet is not a driver of wealth. To find out the impact of reducing fat or sugar consumption on health, I developed a health risk score comparing actual intake to the WHO 2023 guidelines. All countries' scores show severe excess. Even a 20% reduction leaves all countries in the high-risk category. This tells us that marginal improvements fail and transformative change is essential. Harvard research confirms reducing ultra-processed foods by 20% could prevent 1 million chronic disease cases annually in the US. Countries' daily carb intake data reveals that dietary problems extend beyond fat to encompass carb excess. All 5 countries access full carb standards of 1,700 kilocalories a day, and wealthy nations consume processed convenience food, while lower income nations rely on cheap grain staples. Carb and fat excess underscores the severity of dietary intervention needed. To evaluate the economic impact of dietary intervention, I came up with an economic model. The graph shows a strong inverse correlation. As healthcare costs decrease, payback periods increase. This demonstrates that economic wealth fundamentally determines the speed of policy cost recovery. Through dietary intervention, healthcare savings from reduced obesity-related burden offset policy costs. To determine if countries should regulate explicitly or use implicit policies, I identified a tiered framework to match policy intensity to economic capacity. Wealthy nations like the US and Germany can implement explicit sugar taxation plus industry reformulation. This has been confirmed to be effective. UK's sugar tax cuts sugary drink consumption by 15%. Middle-income nations like Brazil and Japan can use hybrid school-based nutrition programs plus community awareness. Finland's school lunch programs prove this work, achieving 8% obesity reduction. Lower income nations like India should employ implicit awareness campaigns and community health worker engagement. This achieves reduction sustainably without taxing poor households. To conclude, each nation must implement context-appropriate strategies supported by evidence. Long-term commitment remains essential for sustained health improvement. Thank you.